Okay. So I'm starting your 2 minutes time. Okay.
Yes.
Starting your 10 minutes time.
Hello, I'm Tania. I am ready for the discussion.
Okay. So what will be your immediate action in this case?
This is a suspected case of perforation following evacuation of the product of conception. And she was primary gravida patient with 10 weeks pregnancy with bleeding and abdominal pain. And ultrasound findings was there is a it is a missed miscarriage, and she needs immediate evaluation and urgent management after involvement of the multidisciplinary team. So as this is a suspected of perforation of the uterus following evacuation of the product of conception, so immediately I need to I will stop the procedure, and I also inform the anesthetist that the procedure will be take longer time, and also inform the my consultant obstetricians or gynecology on call, and of course I need to disconnect the suction syringe after switch it off, and put the cannula inside as it is, because if any movement it can cause injury to the intra-abdominal organs or blood vessels. And also I need to inform the scribe nurse to document everything time to time, and also rest of the operation theater team.
Okay. So now you have suspected the perforation and you decided to discontinue and call colleagues. Okay. So what will be your further approach?
As this is a suspected perforation, so first of all, I would like to perform a laparoscopy, and because we need to check whether there is any intra-abdominal visceral injury like bowel, bladder, or any blood vessel injury. So, with the involvement of the consultant, also we need. I would like to perform laparoscopy. After inserting the laparoscope with proper entry technique, Then the laparoscope will be rotated 360 degree to identify any injury to the bowel, bladder, or any intra-abdominal organs and blood vessels. Then and accordingly we need to involve the corresponding discipline specialist, like we need to involve the urologist in case of bladder or uterine injury, or surgeon in case of bowel injury, or vascular surgeon in case of blood vessel injury. We need to involve the specialty to repair that. If it is possible laparoscopically we can do it, otherwise we need to do laparotomy to repair that accordingly. And also prophylactic antibiotic will be given to prevent infection after checking allergy.
Okay. Okay. Um, what will be your post-operative care in this case?
One thing I would like to mention that during the laparoscopic uh, during laparoscopy, we need to find out if there is any injury or not, and with the laparoscopic guidance, we need to evacuate the content of the uterus so that we can ensure that there is no injury to the bowel or any other organs. And regarding the postoperative management, everything will be documented time to time, and we will admission the patient overnight and closely monitoring of the vitals by news chart. And also, we need to debrief the patient and patient family members and partners regarding what happened in the theater. And also, I will apologize to the patient for what this happened to the patient. And regarding, we need to also explain after debriefing that the perforation of the uterus, it will be considered as risk like classical cesarean section. So in subsequent pregnancy, she should go for elective cesarean section to prevent any complication like rupture of the only scar. And also, I would like to write back to the GP regarding the further follow-up of the patient, and also patient will be during upon discharge, patient will be advised regarding the red flag sign like any distension of the abdomen or any severe abdominal pain. In that cases, she should contact with us urgently with provided contact details.
Okay. What are the clinical governance issues involved in this case?
So this is the this is the complication following surgery. So I would like to initiate the incident reporting, and risk management team will be involved. And whatever the report of the risk management team, as a duty of condor, I will be open and honest. I will explain everything according to the findings of the risk management team to the patient and patient family members and partners. And also, again, I would like to explain that there will be risks of subsequent pregnancy uh, delivery. So she need elective cesarean section. And after that, these incident reporting findings, I mean that according to the review of the risk management team, we have to communicate with the patient and also with the GP because the further management will be by the GP. So GP should be well informed about that, and if this case will be discussed in a clinical meeting. So and also we need to find out the root cause analysis so that we can prevent further events like this type of complication later to any other patient.
Okay. Anything else you wanted to add to any of this question?
So here I can see that the patient is having the mm, 8 millimeter dilator was used. So regarding this patient, it's a learning that we need to do cervical preparation before going to evacuation to prevent injury to the cervix or uterus. And also instead of Vegas dilator, we can use the cannula that is used in manual vacuum aspiration. This cannula can be used around the tip to dilate the cervix. So in that way, we can prevent injury to the, injury or perforation to the cervix of the or the body of the uterus. So this is the learning point, and it can be reflected to the. It can I can give it in my reflective dispersion on the e-port.
Okay. Thank you. Last 20 seconds.
Thank you for your time.
Yeah, thank you. Well attempted. Very well attempted.
Everyone.
Anybody would like to give a feedback to her? Although there is very few people. When the booking was not there, so many used to present, and today many are not there. Why? Any particular reason? Or they are serious enough to now study on their own? Okay. Dr. Shija, would you like to give her feedback? Dr. Shija, are you there?
Ma'am, I couldn't hear the full thing, madam. Sorry, ma'am.
Okay. Dr. Imam, what it is?
Yeah, I think she's good, doctor, because I'm listening to part of it.
Okay. No, she has done a good job. I don't think
Yeah.
there are many points which I have been, which I have to say. So when it comes to answer key, there are hardly any points where she has missed out, and she was very structured. She was giving justification why she wanted to do all those things. So what is expected in structure discussion is you need to be concise, you need to be structured, you need to justify what will be your action. Okay, so this is what she was doing, and obviously the content of that question, so she was using the contents very precisely. That means the keywords were used by her. So overall, a passing station for her. Okay. So uterine perforation by manipulator or by instrument in case of missed miscarriage, posted for evacuation. Okay. So this is an emergency situation which needs assessment and supervision of senior. What will be your immediate action? You need to stop the procedure. So this stop should be very loud. That is what I wanted to tell you, Dr. Tania. I will stop the procedure further. Will not panic. Will not panic. Then you mentioned disconnection of the suction pump. If it is so, not to made any attempts to remove the instrument, because if there are any vascular injury, the bleeding might be there. Inform anesthesis, scrub nurse, rest of the theater team. You informed your consultant also, senior or any senior consultant, whosoever will be available, and call for extra help. These things, did you mention extra equipments, trolley, and blood cross match? I didn't listen to these sentences.
Mm.
Okay, so you have to set, because if there will be for missed miscarriage, you may not have booked her blood. Okay, the equipments may not have been there for the laparoscopy procedure or laparotomy. Huh? So this will be your instructions. Okay, so arrangement of instructions and extra steps. So another IV line also you can mention here. So you can say another IV line, send blood for cross match, because if it will be a vascular injury, the anticipated bleeding and blood transfusion will be needed in this case. Okay, before that, I would like to rule out any jayward witness. So these 2-3 points which was missed in this question. Then the second question, yes, what will be your approach to the surgery? So here my approach to the surgery would like to confirm by going ahead with the laparoscopy. If there will be any injury, then repair of the injury by either laparoscopically or laparotomically. You had mentioned. But this will be done under the supervision of your consultant. Laparoscopy, laparotomy, if there will be any active bleeding, No injury suspected, can be managed laparoscopically. If there is any bowel injury, bladder injury, or vascular injury which is bleeding heavily, bleeding heavily, then in that case we may have to consider it in a open surgery and involvement of other specialists. You mentioned urologist in case of bladder involvement. Bowel involvement, you have to use a colorectal surgeon or your general surgeon, and vascular surgeon in case of any deep vascular injury, but less likely the vascular injury will happen with uterine perforation. Have you seen any vascular injury? It will be common with entry technique, laparoscopic entry technique, but with this surgery it is not possible. Okay, less it is not possible. You may enter into that means you may enter into that uterine vessels, but per se they are very less. Okay, the chances are very less. So expertise will be involved, bowel surgeon, urologist. Decision about the further surgery, okay, that means we are going to evacuate the products, that will be done by a consultant, because there should not be any further damage to the or further increase into the perforation, preferably under ultrasonography guided. Okay, so preferably under ultrasonography guided, proper dilatation will be used of, you will use, ensure whether the priming was done or not. Okay, whenever you will be doing a procedure abdominally or laparoscopically, thorough wash will be given. If there are any chances of injury or suspected trauma to bowel or you bladder, you may consider keeping drain. Okay, drain will also be considered. Now complete the procedure and sign out WHO safety checklist. This word needs to be there somehow, dear, which was missed. Yes.
Yes, ma'am.
Yeah.
Must.
So here, once you are going plan, if it is laparoscopic also, laparotomy also, so your signing off of the situation is very important. Documentation, information to GP, admission for 24 hour at least, news monitoring. Okay, so this was your post procedure care, which is again mentioned in the next prescribe antibiotics. Okay, so this is another point which we need to mention here. Complete the procedure. Now the third question, post-operative management. Complete the procedure and sign out WHO safety checklist. Documentation is very important. OT notes are very important. Complete all documentation. Okay. If product needs to be sent for HPR, will you send it for HPR? Yes. If it needs to be sent for HPR. Patient will not be discharged immediately. She will be shifted to a either recovery ward or a post-operative ward for at least 24 hours. Patient will be monitored on NEOS monitoring chart. It will not be MEOS. Risk management issues will be involved here. Now that is DATIX, that is incident reporting, assess the patient for DVT, alert. Once the patient will be discharged, you need to tell her the red flags and the readmission with 24-hour contact details after discharge. Patient information leaflet after about her recovery care. Okay, about her recovery. Debrief the patient about the incident, of a duty of candor, counsel about implication of perforation on future pregnancy. So you just need to tell her that we wins depending upon the site of rupture, size of rupture, management of rupture, the future mode of delivery will be discussed with the patient at that time. If it is a big rupture, big perforation, she may have to go for a planned C-section. Okay, communicate with GP. You mentioned these points. Okay, so you mentioned most of the points in this case. Only point was this HPR, OT note, documentation. Did you mention? I didn't listen to those sentences. And not to
I don't. I just say time to time everything will be.
yeah, you mentioned that, but then that is a documentation, but that OT notes and all those points needs to be considered here. Okay.
Okay, ma'am.
Okay. Yeah, that is one thing. Uh, do not discharge her. Not to discharge her. Patient will be kept under observation. That one sentence should be very bold enough. Huh? No hurry to
Yeah.
discharge this patient. Huh? No hurry to patient.
Overnight have to stay.
Yes. Yeah, yeah. So what are the clinical issues? You had mentioned almost all incident reporting, root cause analysis, if it is happening, why it has happened, debriefing, duty of candor to the patient, and what measures you will be taking to minimize these complications. Okay, so why this has happened? We need to reflect back. And very nicely you had mentioned, because whether it was an inadequate cervical preparation, the person who was doing a cervical dilatation was not trained enough, there can be a question on this this also, a root cause analysis, clinical governance question on this perforation also. So very nicely you had mentioned many points. So why the perforation has happened, whether it was a inexperienced person, the instruments problem, the patient factor. Okay, patient factor, what could be? If the patients are breastfeeding, the uterus are many a times very soft. In molar pregnancies, the uterus is very soft. Okay, so the chances of perforation is very high. The preparation of cervix is not proper, then in that case also there is a very high chance that there will be a false trauma, false passage, and risk of perforation. So all this will be discussed in colleague feedback meeting. Okay, so that can also be arranged for this case. Colleague feedback, reflective practice, e-portfolio, root cause analysis, and if the things are happening repeatedly, then audit can also be done regarding the same cases. Okay, and we need to learn from our mistakes. It should not be a blame game. It will be, we need to support our colleague who had done a complication. Okay, so this is all about clinical governance task. So very nicely done this also. So when it comes to domain wise scoring, information gathering, basically here, what investigation, what information you would like to ask. So here you can ask also, would like to know the hemodynamic status of the patient. We'll communicate with the anesthetist and check upon the patient status, hemodynamic status. Okay, so that will be your one important point. uh, Further investigation, so what investigation you would like to know? So ultrasonography, full blood count, blood cross match. Okay, so these are the information gathering point. So whatever information has been given to you, interpret that information and then make a clear management plan. That is again a information gathering. Okay, so whatever has been given to you, that is one thing, and how, what investigation you will be liking, that will be another points in the information gathering. Communication with patient and family. So inform the patient after the procedure. Now the patient is under anesthesia, so you will not be informing. Risk management, review report to patient and family. Discuss implication for subsequent pregnancies. Treat as a classical CS. Okay, so this is basically a future pregnancy implication we can discuss, but not a classical CS, and all those points we should not be mentioning here. Just need to explain her the implication of this perforation on her future fertility. Counsel for the red flags to be reported with 24-hour contact details and patient information leaflet. Okay, so this is again communication with patient. Colleague, so here colleagues involvement will be anesthetist, theater team, consultant, senior colleague on call, risk management team, GP, and the relevant specialty if there will be any bladder bowel injury. Safety, to stop suction but leave the tube in situ, to take a laparoscopic decision as early as possible, appropriate steps to complete evacuation and offer antibiotics. Okay, so antibiotics also was missed by you, Tania.
I have said, ma'am.
Okay, you have said. Aware of the risk of bleeding from the perforation and hence need to monitor for some time before discharge from hospital. Include the risk of subsequent pregnancy in counseling. And the knowledge about early pregnancy complication management, and there is no green top guideline regarding the perforation or all those things. There is very nice talk. So basically you just need to observe this patient, intervene, observe, and reflective practice, and all those clinical governance issue. So this was a task once upon, means this is a RCOG task actually. Do you know that?
No, ma'am.
Yeah, so this kind of task was there initially. This is one of the station the RCOG is having.